Hello again, I'm Nenad. I was from Gnomon presenting implementation guide that we developed in the last 3, 4, 5 months. I had much easier job than Giorgio on one side, and on the other side I had much stranger job. The Greek Oncology implementation guide is the deliverable needed for a particular program in Greece, and particular program is part of the I represent, okay. So it's part of digital transformation in Greece, especially part of digital transformation from Ministry of Health. And the main goal is to utilize digital technologies and digitize as much as it possible. There are goals here. I will not go through all of this. The important difference is that I didn't talk with end users. I talked with vendors, and vendors were talking with doctors. What they need to collect and what kind of processes they need to fulfill. And you can imagine when you have a proxy in between, some informations are lost on one side. On the other side, it's easier because it is strictly scoped. 12 hospitals needs to perform in the same way, using the same processes during the cancer treatment. The implementation guide of the whole program covers everything except the early screening. So when there is an initial diagnosis, and further on until at the end of life phase. So actors are, as you can imagine, primary care. They are providing the so-called patient summary, so what they know about the patient when patient enters this kind of process. The second one, secondary and tertiary care, which are executing the cancer treatment using protocols defined by authority in Greece. We need to get on board specialist and diagnostic centers which are acting as a private care to provide the healthcare infrastructure and to enable government reporting, which means that at the end, because part of the project is also cancer registry needs to get the data so they can create the report for public health, but also for sharing with similar registries in European Union. And also some obligations. So Greece has the national interoperability framework, which defined 5-6 years ago how to exchange laboratory orders in intra-hospital and out-of-hospital scenarios. So we need to continue with this effort to utilize the central terminology services, which are not available, but it will be, and to try to, as George said before, bring everybody to the same level of understanding when they are using and describing things in their processes. And to complement with AIFI, AIFI is the upcoming National Electronic Health Record, which will collect data from data sources and provide this data for in first place for the primary care use cases, and then for the secondary use of data. We try to follow refined European interoperability framework, and if you are familiar with it, legal, regulatory and policy is done by the Greek National Health Agency, IDICA, our host, one of our hosts, and we are attaching ourselves in the care process and down. Principles are defined at the beginning. So we started, instead of defining things because we are thinking that this needs to be done like this, we collected the use cases, and as I described before, we are proxy, but we collected the use cases, how this should be done, and more importantly, why, so we can understand and maybe propose better technological approach how to do it. The other one is we cannot force anyone in Greece to accommodate to the new standard, but we can enable them. So part of the deliverables of this program is also interoperable hub, which will give vendors and hospitals time to come up to this standard, and until then to use things which they are already using, mostly HL7 version 2 messages. The next principle is, for me personally, the most important one, and this is that data should be exchanged in context. You cannot send to some guy there, diagnose, code, and date, and that's it. It should be context, which means that information is always in some kind of document, documenting things and keeping these things together so they can be assessed standalone without retrieving data from other sites to be able to understand and come up with a clinical decision. There is a big difference between intra-hospital and external communication. So every hospital needs to send e-prescriptions which are not intra-hospital prescriptions, which are community prescriptions. They need to send this prescription to IDICA e-prescription system. So from there on, patient is available to see and dispenser is available to get it and dispense the medication. Intra-hospital is a bit different. The first phase of this program is to cover the oncological, hematological treatments, which means that treatments via cytotoxins, which we all know as a chemotherapy. So there is a difference. This kind of prescription is completely different from the external one. It needs to contain also the diagnosis inside, why we are prescribing this, and complex instructions about the actual medicine administration. Embrace transparency, which means that we sat together a couple of times in a workshop. After that, we were on a phone calls or mails, but there were focused workshops, multi-hours workshops when we define things. And immediately after that, we start publishing this. So implementation guide is available for all vendors participating in the program. Everything is transparent, and they are aware how things are moving forward and improving. And enable governance. So there is the implementation guide, and information can be governed. So the first one, as I said before, is start with the processes. So we define the processes, how it is going from initial referral to initial diagnostic, finding some cancer marker in the laboratory result. This needs to be, by the law, reported to the cancer registry. There is no diagnosis yet, but you need to report this to the cancer registry. So there are specifics in the process, and we needed to fulfill these specifics with the content specification, but also transport and workflow specification. So formats and protocols, clinical documents and messaging. Messages are HL7 FHIR bundle of type message, which is pretty similar, if not exactly the same as HL7 ADT messages, just in the newer format and more easier transport protocol to handle it. Using, as you can see it, bundles for messages, bundles for documents, and relying on proven standards for exchange of documents using IHE MHD. There is also XDS at the bottom, but people are aware of a RESTful way of doing things. Handling terminology using the profiles. Same is with notifications. So also improving and enabling the care processes and not forcing doctor to click and wait for laboratory result. When laboratory result is available, he or she will be notified immediately and continue with the care process. And of course, authorization and authentication around everything. So the implementation guide is heavily constrained to enable early adopters to deliver the first version. So there are no questions and inside, and there are no optionalities. Minimal data set is needed. This minimal data set is defined. how it should look like, what needs to collect inside, and so on. So messages, medication requests, as I mentioned before, and administration, which are different from the external one. So for internal one, there is a profile. For external one, we are relying on European Union. So for discharge report, oncological discharge report is aligned with the discharge report of European Union in progress. Laboratory order is by Greek. Laboratory result for external one, we are relying that laboratories will send information in European format. Laboratory inside the hospital is different and heavily profiled. What else? Okay. Also, profiling the identifier we saw yesterday, AMCA specifics and what needs to be inside, and profiling codable concepts to enable early adopters and vendors to, instead of producing the document which contains for cancer stage, for instance, and for morphology and stuff describing the cancer, instead of relying on observations, which they really are, we profile it as a codable concept, so you have it inside the diagnose instead of forcing vendors to put multiple observations in a bundle. So keeping everything small, implementable in a fast way. Should I open it and look a bit around it? Okay. So implementation guide contains not just artifacts, it contains also the philosophy why it is like it is, explaining how we came up to this, explaining the ecosystem around it, and also requirements coming from this program. Let's go to the artifacts. So all of these are profiled, and we also profiling the data types and creating the value sets, which are combination of Greek specifics and European or world one. One of the specific of Greece is that SNOMED is not available. Global patient set could be used, but SNOMED as a terminology and classification is not available in Greece. We talked with the authority responsible for clinical terminology, and they provided to us different coding systems which we put inside, so not just for the sake of documentation, but as one of the result of building the implementation guide. You are also getting the FHIR resources which are deployable in the FHIR server, so you have also the terminology services out of the box in a FHIR way. On top of it, as I said before, it's also IHE profiled for getting these terminologies and implementing them in software like oncology information system, hospital information system, nursing administration, and so on. And also examples which are, as I said yesterday, this is the recommendation from FHIR, which I fully agree. When you talk with the business people, they said, okay, we understand, we agree, we will do this. But then this comes to the developer, and developer much easier and faster implement things if there is an example. Not just a specification, but also the one or more example instances, how this will look alike at the end. I think that, that this is it. We can go through it, but I don't think that you are really interested in bits and pieces of it. So, thank you very much.